Hello, I'm Dr. Pfeiffer, the director of the Suncoast Gerontology Center at the University of South Florida in Tampa. Welcome again to our series on understanding and coping with dementia. In part one of our series, we focused on the process of recognition and diagnosis of dementing disorders. In part two, we covered issues related to the management of fully diagnosed patients with dementia, especially Alzheimer's disease. We now come to the most difficult phase in the care of the demented patient, the phase in which institutional care will have to be considered and, in most cases, implemented. The phase preceding death and death itself.
The night times are the worst.
Resulting grief and the resolution of grief in the caregiver, and finally, the resumption of life on the part of those left behind. We have titled this part of our series on understanding and coping with dementia, Course and Outcome.
Tom,
want to get up? Tom, you want to get up? All right?
Yeah, it isn't very well because you're still looking at the well.
What do you got in your pocket? You got something from the lunch?
Yeah.
There's nothing in your pocket. It's just paper. I'll fix your hair up a little bit.
We have learned that the best place for the patient with Alzheimer's disease or one of the other dementing disorders is at home, if a willing and able caregiver is available. As the disease progresses, this becomes more and more difficult. As more cells are lost, more abilities are also lost, increasing the demands on the caregiver dramatically. Meaningful conversation no longer exists, and the patient may no longer be able to make himself understood. There is now deterioration of self-care capacity. Not only may the patient now require help with eating or with toileting, but he may not be able to cooperate at all in these activities with the caregiver.
You want to go to the center? I don't want a nursing home. She can stay with us. It's a small house. We can stay together. And the main thing is as long as my health holds up. I've talked to a few nursing homes. First of all, I know 2 nursing homes that I've talked to were doubtful because they say they've had too much experience with those that have become incontinent and they become bedridden and they become, they need complete care. We've been married 47 years, see? And during that 47 years, we were together more than 3/4 of the time. I can say that truthfully. I mean, half of us is affected because we've been so close. We were both just the 2 of us. And the main thing is I was worried about is whether if anything happens to me, what will happen to her.
Well, the
I think I've got things fairly well arranged. But for how long, I don't know.
The growing problems caregivers now face can include incontinence, hostility, constant yelling, refusal to dress or bathe, and daytime and nighttime restlessness.
Then the time came when she became incontinent, both of bladder and bowel. And that was about the decision point.
I had gone through the incontinency and the not being able to feed herself. That wasn't strong enough or bad enough to do that, to put her into a nursing home. But when she got to the point to where I couldn't get her up and down stairs,
I really wasn't ready to give him up. I didn't think anybody could give him as good care as I could, But I realized that I was getting pretty well tired out. And my neighbors and friends, of course, were forever saying, Dorothy, you must give him up. My husband became psychotic. He had gone berserk. So he had taken off his shoes, gone to the bathroom, taken his teeth out, picked up a chair, and was about to throw it through the window, totally disoriented, abusive verbally, and so forth.
At this stage, the caregiver may no longer be able to provide the around-the-clock care which is needed. Institutional placement will now have to be considered, a most difficult decision for most families. What makes decision-making about institutionalization difficult are several factors. Caregivers may feel that they are giving up on their relative or that they themselves have been defeated.
Ready for another bite? Open your mouth.
We didn't have everything going for us, but we still had companionship, and I didn't want to lose that.
You really did well.
And then I guess I didn't want to lose control of the situation. I had him at home. I could go look at him, satisfy myself, turn him over, see if he had a red spot, and that sounds a little bit like I think somebody else couldn't do as well as I could.
Caregivers may feel that the patient does not want to be in a nursing home. Caregivers may have misgivings about the quality of care available in nursing homes, or they may criticize themselves, or they may feel criticized for, in quotes, abandoning the patient.
It took me about, I would say, a month to 6 weeks to actually accept the fact that I had done the right thing. I had this guilt trip going, and the house was pretty empty. But little by little, you sort of sublimate and fill your life up with other things. And the fact that I can come here every day, and he's only a couple of miles away, means a lot to me.
I think that a lot of the reticence to put the patient in the nursing home, in my case, was fear that she wouldn't be properly cared for.
But there are several things which can help families in this difficult decision-making process. First, institutional care may very well be the very best place for patients in the final stages of Alzheimer's disease. The decision for institutionalization should not have to be made by the family alone. In fact, the primary care physician should help to make this decision. There are some very useful guidelines about when institutional care is the most appropriate form of care.
I try to help the families make the decision to institutionalize the patient. I feel that the physician's role in this decision is very important because oftentimes the family will become so tied up in the emotional aspects of it, their guilt, their exhaustion, all of these things playing such a heavy role for them, that it helps if there's a third person who's involved in the decision who can be a little more objective.
Other criteria include inability of the patient to cooperate in his or her own care, requirement of continuous 24-hour-a-day care and assistance with activities of daily living, and finally, and perhaps most tellingly of all, inability of the caregiver to go on providing care for whatever reason. Once the decision to institutionalize has been made, we must now find and choose the appropriate nursing home for a particular patient. Regrettably, there are as yet only a very few places in this country that provide specialized care for patients with dementia. We are therefore concerned with making the best choice for a given patient and family. We start out with the assumption that there is no perfect choice, but that there are choices available. In choosing among available facilities, we would emphasize the need to shop around, the need to visit possible facilities, and to interview staff at those facilities. Perhaps best of all is to talk with family members who have had relatives in specific nursing homes. That way you have a very good chance of getting a user-proven nursing home for your patient.
As a social worker who's been involved quite closely with families who have patients with Alzheimer's disease, there are 3 things that I want to discuss with those family members when they're in the process of choosing a nursing home. One of those first issues is helping them to decide on a facility based first on the quality of care that can be offered to them at that nursing home. We have 3 or 4 family members in our support group who have chosen the same nursing home. That did not happen by coincidence. We're sisters under the skin.
I wanted to keep Harold home. Home's a good, warm word to me.
Well, Marion, you and I talked about it so much, and I talked about this nursing home that was so good.
Well, I really came for, emotionally I wasn't ready, but intellectually I trusted Ruth an awfully lot because we discussed other decisions we'd made about our husbands, and we thought a lot alike. So I wanted to come see Lawrence anyhow, because I felt close to the relationship there. And although I had this dirty word complex about institution, when I saw the home-like atmosphere of this particular nursing home, that reassured me a lot.
I was happy that Dorothy told me to come down here. I did check with her every few days how things were going with Abby to see how he was doing, and that helped me too.
I think we've all done a follow-up on each other.
It reassured me.
Secondly, then, I want them to look at the appropriateness of the facility in terms of its construction, its location. Cost is the third variable that families must consider when they choose a nursing home. Now, this is the variable that they have the least control over.
Once the nursing home has been selected, the job now becomes making the nursing home work for you, for your patient, and for the family. The key word in all this is communication, communication, and again, communication. Communication between the doctor and the nursing home staff, between the doctor and the family, and between the family and the nursing home staff. And here, what is being communicated is not nearly as important as how the communication is carried out.
Hi, your mom had an accident this morning. She got up in the chair and fell and cut her head about 1.5 inches behind the ear on the right side. And it's bleeding kind of profusely. We've got it stopped, but it's going to need some stitches.
We start out with one very basic assumption, and that is that making the nursing home work is a learning process, and a continuing learning process at that. The choice of a nursing home should allow for continued family involvement.
I had to take her over to St. Joseph's for emergency treatment. I can't tell you how nice it was, the cooperation I received over there.
Right.
They only had to shave a little area on the head.
When I see something happening that I feel he's been neglected or has not been taken care of, then I go through the chain of command. I first find out who his aide is and discuss it with her and give her the opportunity to rectify the situation. If it has not been changed the next time, then I go to the nurse on duty and give her the opportunity. If it still persists, then I go to the director of nurses, because I feel that I cannot continue to see these things, plus the fact that if you don't have a little fire and meet the challenge, you can't stay in the nursing home and your loved one there.
I would help the nurses. I'd put bibs on the people in the nursing home. Of course, this gave the aides a little more time for themselves, and it helped.
Your approach to the patient has to be so loving and so patient until you're going to have to find this willing to extend for the staff to extend themselves to the patient. The patient cannot talk or communicate as a rule, except by very, to some age, they might feel that they don't like being kicked at or the way they communicate. So you have to find somebody that's willing to extend themselves beyond this type of behavior and see the person. And I see that here among these aides. They take verbal abuse, and they have to deal with various functions, body functions, which are trying and to keep them clean.
If you sit down placidly and accept an Alzheimer's patient and do nothing to try, you are lost.
The nursing home, however, is not the only setting in which care can be provided for the patient with advanced Alzheimer's disease. Occasionally, and under very special circumstances, a special board and care facility may also be able to meet the needs of the patient and the family, as we can see here in the case of the Lastra family.
Good morning, baby.
I put my husband Arthur in this private boarding home because I found that he would get better care here than anywhere else I had investigated.
Feel today, eh? Come on. A ver, acuéstate, mi vida. Acuéstate. Vamos a quitarte los pampers.
He is totally incontinent, has to sleep with diapers on in the nighttime.
How you feel, honey? How you feel, baby?
Maria, who owns this boarding home, takes very good care of Arthur. Early in the morning, when she first gets him up out of bed, she takes him to urinate immediately.
Come on, Arthur. Come on. Come on, little boy. Hey! Good morning. Good morning. Come on. Come on, let's go.
She does everything from start to finish with him. She gives him his bath, she shaves him, she feeds him. I don't believe Arthur's ever been happier in his life.
Come tú solito, ¿eh? Ay, tiene frío, pobrecito. Ay, mira, qué frío tiene.
He is the only Alzheimer patient here of out of 3 she takes care of.
Qué bueno está eso, ¿eh?
There are no words to describe Maria. She is just heaven sent, and I really believe she was heaven sent for Arthur. And she takes perfect care of him like it was her own husband. I really have a little guilty conscience that I'm not able to be like her. And there should be more like her in this world.
Oh, Arthur. Oh, very nice. Okay, Arthur. Eso va, eso va. Eso va, Arthur. Very good, Arthur.
Alzheimer's patients need to have one-to-one care every day and take him out for a walk so he gets his exercise, which is very important for Alzheimer because they do want to sit and do nothing a lot of the times. Okay, Arthur, let's go. Okay? Bye.
An even more innovative approach to the care of the patient with advanced degrees of dementia is through the use of hospice services. The Ackerman family have been very successful with this approach.
My husband has now almost completed 13 years since he was diagnosed as having a presenile dementia.
Oh, you're getting tired, aren't you, huh?
Hospice is a service that provides the nurse that comes once a week, Susan, who is the social worker, and she comes to more or less to build up my morale. And she goes in and talks to Bob, and Chris is the guy that helps out with all the bathing and shaving and fixing the sores, and he's the male aide. In a nursing home, I would go and visit Bob. I would feed him. I would sleep when he slept, sitting in a chair. I would feed him again. I would help him, get him cleaned up and whatnot. Then I would rest again, and I would have no activity of my own at all. But here, I'm free to go out and dig in the yard. I'm free to sit down and write letters on my typewriter. I can clean my house. I can live a normal life and still take very good care of Bob.
There are 3 criteria for most hospices, and that is the first, that they have a primary caregiver, someone to assume major responsibility for their care in the home. The second is that they have a life expectancy that can be measured in terms of weeks or months, usually with 6 months or less being the cutoff. And the third is that they have a physician's referral, that their doctor refers them to hospice care.
Communication among all the involved parties is especially important in the nursing home because a number of medical conditions can occur which can falsely alarm the doctor and the family that death may be imminent. The patient may look moribund, but the cause is quite a simple, treatable condition.
In order to improve communication with the nursing home personnel, I've found it's very helpful for them to have my home phone. That way they can call me promptly if there's a problem. If I'm not available, they do have the answering service. But often I can clear up something very quickly, or I can react to an impending crisis in a more appropriate manner.
But death does come eventually to the patient with dementia. The approximate cause may be bronchopneumonia, but the ultimate cause of death is Alzheimer's disease.
She died because her heart stopped beating. So on her death certificate, they put cardiopulmonary failure or something of that nature, and I said to the doctor, I said, you know that this was all caused by Alzheimer's? He said, yes. I said, well, put it on there. Because I didn't want her death recorded as another heart condition death. I wanted it recording as an Alzheimer's death. And he did.
My wife Janet died of Alzheimer's disease. However, the actual death would have been from pneumonia that was brought on by Alzheimer's disease.
Family members are often quite astonished at how much grief they experience at the actual death of the patient. They've done considerable grieving ahead of time, but the actual death comes as a totally new experience to them.
I was glad. I'd been praying for it. But when it happens, it's the finality of it is overpowering. Because we've been together for 47 years. And I still react very much to her being gone, as you can see.
They called me at about 7 o'clock one morning and told me that she was in very bad shape. And I went out there and she died at about 3 o'clock that afternoon.
Now the siege has ended. While there may be a sense of grief and a sense of relief as well, there also comes over the caregiver a sense of emptiness, because he's now a caregiver without a job. What next?
Well, I don't know. I guess I miss her all the time, but it bothers you more when when you're by yourself. Being alone is a very difficult part of it.
As you can see, there's a hell of a lot of grief there and loneliness. Surely, I've been going back to the nursing home, as I told you, twice a week. This has helped a lot.
I finally realized that I was starting to be very depressed and reclusive. So I finally decided a couple of things I had to do. One was to try to forget the bad times and just think about all the good times. And I have been doing that to the best of my ability. And the second thing I decided to do was to get in the car and go away on a trip, to change the scenery, to visit old friends and relatives. And I did that.
Many people in this situation engage in a kind of quiet quest. They go on journeys to visit familiar haunts, long-lost relatives, old friends. They're really making a journey into themselves. Some remarry. Others remain actively involved in programs for Alzheimer's disease, in research and in clinical services.
When my husband has died, I have a deep commitment to hospice, and I am going to be a volunteer.
My husband has been dead a year last Monday, November 7th, and it doesn't seem that long.